We'll move on to the next presentation, and the next presentation will be by Dr. Ashray Naik again, in place of Dr. Chandra, and the topic will be management of dry and lost in the world of anti-VEGF, dry AMD, current understanding, approach and management, preferred practice guidelines for dry AMD.
Thank you, sir. Thank you, RC, for the opportunity for Chandra. So, since Chandra is not here, I would be presenting behalf of my friend. So, as we know, aging as an epidemic, though in the last, though we have the demographic dividend, which we have quite a big population, but by 2050, our old population will triple, and we'll be having nearly 2 billion patients around the world. And with aging population, we'll also have few problems emerging out of these geriatric population. So age-related macular degeneration is one of the leading causes of irreversible vision loss in the elderly population. And in the initially at 50 years, only 1.6% of the population will be usually are affected. And by the end of 75 years, this incidence increases to almost 30%. So in India also, it is in the range of the prevalences is in the range of 1.8% to 4.7%. So whenever patients develop IRMD, they have these initial symptoms such as blurred vision or a distorted vision or metamorphopsia. Then there is an alteration in color, or there can be a central scotoma. So ARMD is grossly divided into non-neovascular or dry ARMD, which is the focal point of our discussion today, and the other one is the wet ARMD. So this is how you might have a few drusen's involving the macula. So dry macular degeneration accounts for about 90% of all AMD cases, and also called as atrophic non-exudative or drusenoid macular degeneration, and are usually characterized by abnormalities of RP Brooks membrane and choriocapillaries. So usually they also end up with permanent vision loss due to conditions such as geographic atrophy. So this is mainly due to the reduction of blood flow to the RP, and as and when the continuous metabolism of Brooks membrane causes these metabolic debris, they accumulate and form drusen. And again, these constantly needs to be removed with the help of dicer mRNA. But as we age, this gets deplenished, and the photoreceptors and RP degenerate. If the degeneration is too much, then there is VEGF release, and because of VEGF, there is a proliferation of new vessels and the breakdown of RP Brooks complex, and the new blood vessels end up in causing the scarring of the macula. In wet RMD, they do cause CNVM, and all the discussion, all the treatment modalities have been discussed earlier. So these are the risk factors. Older age, as I told, once you are 75, the risk increases by many folds. So cigarette smoking, family history, and low dietary intakes of antioxidants, vitamins, and zinc is definitely an established risk factor. And these days, the emerging one is a high light exposure with constant exposure to screens and so forth. So what happens is there is oxidative stress, which is the main root cause of all the problems in the RP Brooks complex, which leads to age-related macular degeneration. Oh, sorry. So basically, the effect is due to the oxygen-free radicals and advanced glycosylation end products, which causes the damage to the RP and Brooks membrane. So this can be easily be to a certain extent mitigated by using antioxidants. Because we have oxidants, we can use antioxidants. So that is why we use these drug supplements, and which drug supplement is basically based on many observational studies, based on diet and nutrient intake, and also the macular xanthophylls, lutein and zeaxanthin, which have been associated with lower risk of prevalence and incidence of AMD. So initially, beta carotene was used because it is not synthesized by the body and also has an antioxidant capability with a dose of 15 milligram per day. However, it can be naturally procured, but it was in ARETS 1. So in another drug, another vitamin was vitamin C for similar reasons, along with vitamin E. And with zinc, they used quite a high dose of 80 milligram initially, and it's a trace element. So because of the high zinc, the copper deficiency used to occur, so they supplemented with copper as well. So after the AIDS, after the ARET study, what they observed is it was not affecting the visual outcome. So even the placebo group and as well as the antioxidant group were very similar. So in the first ARETS 1 study considered that those with initial stages of advanced AMD or vision loss due to AMD in one eye and without any contraindications such as smoking should consider taking a supplement of antioxidants plus zinc, such as that used in this study. But however, the advantage was not very palpable. So, and again there were few shortcomings in ARETS 1. So one is the beta carotene increased the risk of lung cancer, and also, as I earlier mentioned, the high zinc concentration, only 25% was getting absorbed, 25 milligram of 80 milligram was getting absorbed, and also the zinc was causing GI disturbances. So since lutein and zeaxanthin are already present in the macula, they thought that it would be a good option to use it as well. So, and omega-3 fatty acids as well were used as it had an role in the visual development and the retinal function. And retina also had a high concentration of docosahexaenoic acid, and eicosapentaenoic acid was also used in the DHA biosynthesis. So it thought it's a good precursor drug for these elements to work in macula. So finally, in conclusion, on this lutein, zeaxanthin, DHA and EPA were added. However, most of the drugs in India don't have this complete, 80% of the drugs don't have this ARETS 2 formulation. They always come with additional adjuvants such as the ginkgo biloba, bilberry extract or pine bark extract. So we need to be very careful about it. And in ARETS 2, again, the number needed to treat was quite high. Out of every 17 patients, only one patient got benefited. So it is a natural question that whether it is of really any use to our patients who have high comorbidities. So, however, patients who can be substituted with these ARETS 2 formulation, because it is believed to increase the macular pigment optical density, which can give positive effects on the visual performance such as glare tolerance, glare recovery, contrast sensitivity, Amsler's defect, and chromatic aberration. So adding zeaxanthin and lutein provided 20% reduction in progression beyond the original ARETS. So hence this formulation can be used to prevent the progression of early dry RMD to the advanced dry RMD. And however, these things are very important to prevent or delay the progression, such as UV protective glasses, and in terms of low vision, due to dry RMD, low vision aids and visual rehabilitation has to be used. And in patients with good vision, AMSL monitoring of their vision is extremely important to safeguard their vision. Thank you.
Thank you so much, Dr. Ashray. Dr. Tirumalesh, what is your take on the antioxidants in dry AMD? Tom, Mike, did you?
Otherwise, I don't start. Intermediate being, intermediate size or large size drusen, and if associated pigmentary changes.
And you've seen benefits?
I mean, that's the recommended treatment.
Yes.
So one should follow that. I mean, usually antioxidants is started even with smaller drusens which are scattered all over. That's not really required. But if the patient has an intermediate drusen, or if the other eye has been lost and this eye has even drusens present, you can probably start. That becomes a risk factor. So AREDS 2 had clearly defined, if you have a very large drusen, start it directly. If you have an intermediate size drusen in both the eyes, that becomes an indication to start. And if you have only small size drusens, then there is no real indication to start the treatment. So basically, these kind of reduce oxidative stress. But what one should remember is, despite starting these medications, still 1/3 of the patient will progress to the next stage. So follow-up of these patients is extremely important. And like I said, use of omega chain fatty acids is not really required, because the dosage that was required, and it only provided protection against dry eye, but it did not provide any benefit from the retinal point of view. So that way we still don't have the ideal treatment for treating.
Just pulling this question a little further, one of my relatives who Dr. Pooja is treating for dry AMD, her daughter in Stanford went and got a genetic something testing done, and that said that when you are of age, then you are also likely to get AMD, and now she is in a panic mode of what can I do to prevent this. What do we answer to her?
So the point is, there are about 250 genes which have been identified, which are all associative genes, of which two are important. One is the CFH, there is the ARMS2. These are known to have a very high predictability ratio. But as we all know, that just having the genetics is not enough. Along with the genetics, there has to be exposure to the, to the blue spectrum that's usually known to be the risk factor, exposure to sunlight on prolonged durations and all that. So just having the genetics doesn't mean you're going to get the disease. Until and unless you are, getting exposed to sunlight, you can advise her to probably wear sunglasses whenever she is out. And I think beyond that,
Dr. Raja, your take on this?
Yes, actually, such an important topic, question, and patient impact of patient being anxious. There are multiple ways of interpretation at this point of time. Nothing concrete, I would say. But a few points, I generally don't give AREDS formulations. It's not been done on Indian population, and not just that reason. In India, the dry AMD is different from what you see in the West. Totally different. I've worked in the US, I've worked in India. It's totally different. And even there, when you look at the results, I don't think it was effective. It's just kind of a walking stick support kind of treatment, placebo treatment, maybe marginally better than placebo treatment. But recently now, the pegcetacoplan has got approval in the US for dry AMD. And that's a big changer in the sense it's intravitreal injection. Every dry RMD patient is now going to get intravitreal injection. And if you know, among all ARMD patients, 90% are dry RMD, only 10% are wet ARMD. So with antivegf, we have been giving for wet ARMD only 10%. Now in 90% of patients, if you start giving, you will have to open shops all around, not just in ophthalmology clinics. But that has different caveats. I don't think we'll go into that. But the point which Dr. Sinha raised is when to advise a test, and if you give a test report, be prepared how to answer and tackle the patient's queries. And the way you have brought out, I don't think that's ethically correct to tell a patient to get a testing done and then say you are at a higher risk. Higher risk from 0.1% to 0.2%, or higher risk from 1 to 2%, or higher risk from 10 to 20%, or higher risk from 50 to 100%. All these have different meanings. And if that has not been properly counseled to a patient and make them panicky, that's why the genetic counselor, or that cannot be done by everyone, and just like even I should not be doing it. are
We,
not trained
we
for
didn't
that.
ask her to get it done. She has
No,
got
no.
it done herself in Stanford.
Yeah, no. What I'm saying is that I am not trained to do genetic counseling. I cannot say okay, I will do this test and I will only tell you are at increased risk. And I have had this personal family, my own close family member had this problem that someone said your baby is going to have a high risk of Down syndrome based on this testing, and they go panicking. And then when you realize that risk has increased from 1 in 5,000 to 1 in 4,000 probably. But if we don't do those counseling correctly, it will lead to a big problem. And there is no way that you can say you take this medicine so you won't get it. So the counseling has to be appropriate.
So thank you very much.